What's up, everybody? This is Greg from the Medic Assessment. I am super excited today to come to you with a video with our first education portal for the summer. The topic that we're going to be talking about today is RSI, or Rapid Sequence Intubation. Alex and I have a lot of history in regards to RSI. We've been doing it for a very long time. So we're going to put some stuff out there for you guys to watch, to listen, to think about, to comment on, and hopefully you learn a thing or two. This is the first of several education videos that we're going to be doing throughout the summer. They do take a while for us to edit, which is why it's been about a week into our summer content prior to us really wrapping up this video and finishing it up. But we are excited about it, and we hope you are too. So let's get started. So I break up RSI into 3 different parts when I'm teaching my new students and new employees at my organization. And this is just my own personal way that I kind of look at it. I break it up into part 1, which is purely assessment and preparation. Do you have the equipment available? Do you have, things in front of you? Are you thinking 10 steps ahead? That kind of thing. We'll talk a lot about that. And then part 2 is the actual interventions that you're performing on your patients. And then part 3, very importantly, is the post-RSI care, which a lot of people forget about. We'll talk about that and then do a quick outro and then move on from there. Who and what is this presentation for? So this presentation is made by Alex and I at the Medic Assessment. Again, it's a purely biased presentation. We have a disclaimer at the beginning of it. And all of our experience comes from research-based, medical direction under the physicians that we work for. But this presentation is for those who want to know more about RSI, the new student, or for those that have been in the field for a long time that just want to pick up some little pointers that might help them on the next RSI that they do. So RSI, again, what is it? We talked about that, rapid sequence induction. I'll give you my definition behind it. What is the goal of RSI? We'll talk about. How is it performed? And, excuse me, more importantly, who is allowed to perform an RSI? And Alex and I differ very much on our opinion about who should be allowed or the amount of people that should be allowed to perform an RSI. So my own definition, and this might be similar to any other definitions that you might hear in medicine, but my definition of pre-hospital paramedic, specifically pre-hospital paramedic RSI, is that of a highly skilled medication-assisted airway procedure that is performed out of an emergent need to establish airway protection and patency. Now that's kind of the best way that I can describe it. And for those that don't know, and again, maybe this is more towards the layperson, but what that means is that as paramedics in the field, we are performing a procedure, an advanced airway procedure, with the use of medications that allow us to temporarily paralyze our patients, sedate them in addition to that, in order to take control of their airway, in order to essentially save their life, right? So they're in a situation where they're not able to control their airway, or they have some kind of morbidity that has damaged their airway in some regard, and we have to get a definitive airway, not a supraglottic airway device, which I'll talk about, but a definitive airway in place in order to maintain it in terms of our overall treatment, and then in regards to everything else that we're currently doing for that patient. Now, that being said, and again, maybe I'm talking to the layperson or those that don't know medications, they hear the term temporary paralysis, and that's kind of where their eyebrow gets raised a little bit. And that inherently is where the most risk comes in with this procedure. Now, it's a combination of different things. There's many, many things that are going into performing this procedure and performing it correctly. And a quick side note to that, you either get this procedure 100% correct, or you get it 0%, or you don't do it, and I'll talk about that. But it's a procedure that you cannot get wrong. You have to do right. You have to do it right every single time, and you have to know what you're doing. But people hear that, and inherently that raises your eyebrow a little bit, and that's where the risk comes in. Is the medications we're giving to temporarily paralyze somebody, and we'll talk about why that is necessary. More importantly, in terms of physiology with our patients as we're managing them. So there's different kinds of meds that we use during this procedure. Pre-induction, which is prior to the actual induction that we're doing, and a lot of that has to do with pediatric airways. Again, another side note, this presentation is based more on adult airway management and adult RSI. We'll do a separate video just about pediatric care and pediatric assessments. But for the purpose of this video, we're kind of sticking to just the adult airway management. So we have our pre-induction medications, and some people call them agents. I think Alex calls them agents. I call them meds, whatever. And then your induction agents, your paralytics, and then your post-induction agents. Post-induction, I'm going to talk a lot about as phase 3 because it's a phase that I've seen many clinicians not intentionally forget about, but there's so many other things going on during this RSI and during this procedure that some of the things that they should be doing in that phase 3 get missed. All right, so before we move on to some of the kind of the meat and potatoes of this presentation and how we talk about educating ourselves and other individuals in RSI, Alex and I differ very much in this next point, which is kind of why I wanted to talk about it. So, in my opinion, and again, that's a very biased opinion, RSI or a rapid sequence induction or medication-assisted intubation should only be performed when there are 2 paramedics present on a scene. And the reason for that is because, and again, this is biased, but I work in an organization where we only employ paramedics. We don't employ EMTs, and every single one of our paramedics are critical care certified. Now, I have found that to be the best environment to do not only RSI, but really advanced medical procedures that a lot of other medics and clinicians around the country can't do. It allows us that kind of opportunity, and I've had a lot of success in that regard. And the reason for that is because during an RSI, when you have 2 paramedics, you have one person whose sole responsibility is to manage that airway. We'll talk a lot about the steps and that goes into that. And then your partner or the other paramedic is solely in charge of the medications that are going to be administered. So then you might be asking, well, then why can't you do that with an EMT? Well, when it comes to medications and very specifically paralytics and sedatives and analgesics and things like that, EMTs are not allowed to draw those up, and they're certainly not allowed to administer those medications. That is required by the paramedic. That's why we're paramedics. We're a higher level of certification in the same way that nurses and PAs and docs and everybody has their own level of certification. So EMTs, by law, they're not allowed to draw up and administer those medications, in addition to the other job that is required during an RSI, which is airway management. Now, airway management in this circumstance or this procedure that we're talking about requires an intubation or an ET tube. Paramedics are one of only a few professionals in healthcare that are allowed to intubate. EMTs are not allowed to intubate. And maybe that's something that the layperson might not know. And Alex and I have talked about that on the podcast, the difference between medics and EMTs and kind of where the public's view of that is a little bit skewed. And everybody, has their place. EMTs and paramedics, everybody in medicine has their place. But EMTs are not allowed to intubate. So you have 2 jobs during this procedure that require paramedic level certification and paramedic level skill. So if you only have one paramedic, then you're kind of bouncing between, 2 different jobs. You're doing the meds and then you're swapping out with your EMT partner and doing the airway. And that might work in some circumstances without question. And there might be services that can only do that or they prefer to do that, which is great. Again, this is a very biased opinion. It's my opinion about it. But I find it better to have the highest level of pre-hospital certification in those 2 clinicians both taking those jobs and working parallel to one another in order to achieve success during this procedure. So I hear the argument a lot, professionally, of course, is that, if you have a paramedic and an EMT, why don't you just place the EMT on airway management and you place the paramedic on medications to draw up, to administer, and that kind of thing. And yeah, that works, except the EMT is not placed in an ET tube. They're placed in a supraglottic airway device, and there's several of them out there, which I won't get into. And the problem with that is twofold. So a lot of patients that I have RSI'd over the course of my career have either inhalation injuries or are in anaphylactic shock with severe anaphylaxis that is closing off their throat. Both of those kind of patients require an ET tube in order to secure their airway. Placing a supraglottic airway device is not going to be sufficient in that regard. And the reason for that is because a supraglottic airway device rests above the vocal cords. An ET tube is placed in the vocal cords. It's definitive. So say you have anaphylaxis with an ET tube. You've successfully placed an ET tube in a patient with severe anaphylaxis. Swelling might occur, but it's going to occur around that ET tube, and it can't be closed off. A supraglottic airway device is above that portion that could be closed off, and now you're behind the 8-ball. Now the next step that you have to do is a surgical airway. So in my opinion, again, this is a biased opinion, but a lot of those patients that I've intubated require an ET tube. And if we're not ending in intubation, which I would agree that we don't need to end in intubation, but then we're doing something else. We're doing an RSA versus an RSI. So there's a distinct difference there between supraglottic airway devices and ET tube and how they are used in regards to overall airway management, and the disease process that comes with the patients that we're managing in these circumstances. But those are, again, biased opinions and based on what I've seen. There are plenty of statistics and studies out there that show that you get too many clinicians in a room and too many paramedics in a room or too many docs in a room, and I like to call it, there's too many cooks in the kitchen, right? And in that regard, to the flip side of that, I very much agree with that, right? There needs to always be a leader on a scene. There always needs to be somebody who's delegating tasks appropriately. But I'm lucky enough that the organization that I work for is phenomenal in regards to how we operate as two paramedics on a scene and whose patient it is and who's running the call, and who's kind of assisting the other paramedic. So again, I think it works better with two paramedics. That's not a necessity, even in the state of Minnesota and other states, and in some states it is. So it's really service dependent. It's obviously totally dependent on your medical direction, but that's kind of my opinion on it. And with that regard, I'll show a quick video from Alex, and he'll give you his opinion on who should be performing RSI or how many people should be there during an RSI.
What's up, guys? Alex from the Medic Assessment here. I hope you're enjoying your summer. I'm actually here at my home in beautiful Dakota County, just outside of St. Paul, Minnesota. And I'm here to answer Greg's question of whether you need 2 advanced life support providers to perform a medically assisted airway management. Now, sometimes we call it RSI, sometimes we call it DFAM. I've seen that in the literature, delayed facilitated airway management. So long as we understand that it doesn't have to end at intubation and we should never do it rapidly, I don't care what we call it. So let's talk about advanced life support providers. Should we have 2 of them? Not now, not ever. And here's why. We need to take the opportunity to train our EMT and AEMT partners to be just as good as we are, no matter what the case may be. They should understand those protocols inside and out, not just the parts that say that they can assist a patient in taking their own nitroglycerin. That's simply put why I don't think you have to have 2 ALS providers. Good training means good results.
All right. Thank you for that, Alex. So moving on. So as we get into this, the first thing that I always teach is you should be asking yourself a few different questions. But more importantly, the first question that you should be asking yourself before you do anything else, before you're drawing up meds, before you're pulling out equipment, before you're thinking anything else, you should be asking yourself, what anatomical and clinical findings would prevent successful intubation? Now, that includes potential injury, burns, things like that, or facial hair, or obesity, pregnancy. There's a lot of different things that go into managing an airway, and more importantly, there's a lot of things that can make an airway very difficult. Those of us who have been doing this a long time, who have intubated a lot of patients, we all know that every single airway is different. I think the most comfortable clinicians on the planet that are with airway management are MDAs and CRNAs. That's because they intubate people every single day, all day long, right? I mean, they're inherently going to be able to look at an airway and be like, that's no problem, or I'm going to do this, or whatever it might be. For us in the pre-hospital setting, and I would argue for like physicians in the ER, for instance, who are another clinician who can intubate, we don't get to pick and choose which kind of airway we see on any given moment, and they just are presented to us whenever somebody calls 911 or whenever somebody walks in or comes into the ED. So in that regard, you have to be very quick in your assessment of a difficult airway. Now, if you were to go into surgery and you were going to go under general anesthesia, for those that have had surgery before, usually the anesthesiologist will come in, or the CRNA will come in, and they'll look at your neck, they'll look at your airway, they'll have you open your mouth, they'll look at your tongue, they'll look at all those kind of things to get an idea of what they're going to be working with when they're doing surgery. We obviously don't have that opportunity in the pre-hospital setting. So things like tongue, for instance. Sometimes when I'm intubating a patient, a tongue is really malleable. I can move it without, any real difficulty. And other times it's very much a obstruction to an airway, and it gets in the way of intubation. So just, you have to look at that, and that's one of the parts that you have to do relatively quickly during this scenario, because you have to make a decision right off the bat. Is this a difficult airway that I'm going to be able to manage, or is this a difficult airway that I won't be able to manage? Because if I take away their airway, or if let's say that they're currently breathing but not well, and they're giving me a reason to RSI, am I taking away their only current respiratory status and then not being able to intubate because they have a difficult airway? Okay. So the first thing you should be looking at is what anatomical and clinical findings would prevent a successful intubation. And you're not going to be able to see everything. All right. You might look at a patient, they might look, like it would be an easy intubation, and then the moment that you get in there, you find it out to be difficult. But that's why we go through our process, which I'll talk about a little bit later. And it's also not just what you see, it's what you hear, right? Okay, so in addition to things that you're looking at your patient, are you hearing stridor? Are you hearing gurgling, a hoarse voice, grunting? And also, do you see any, things like accessory muscle use, pursed lips, tachypnea, seesaw respirations, all those kind of things? All of that plays into your quick assessment of an airway, and how difficult it's going to be, and what are the things required for this patient, for my patient physiologically, in order for me to be able to perform this RSI. And if they are not giving me enough things that make me feel like it's going to be successful, or if the risks of this procedure outweigh the benefits, which I'll talk about, then it's something that we should not be doing. Okay, and I'll touch on that point in just a moment here. So the next thing that you want to do is your risk assessment, which I just kind of said, right? So what are the benefits of this RSI? Is this patient going to benefit from me giving them and establishing a definitive airway, and the risks that would potentially come with that? So in addition to your benefits, right, it's a pretty clear-cut decision when, say, you do have inhalation burns, or you do have some kind of trauma or injury or whatever it might be, that in the next minute, or the next 5 minutes or 10 minutes or an hour or whatever it might be, this patient is going to lose their airway. If they lose their airway, they're going into respiratory arrest. If they go into respiratory arrest, they're going into cardiac arrest, and they're going to pass. So what benefits do I have for establishing this airway? Is it to save their life, to prevent future morbidity? That's an easy part of the assessment. But the risks that also come in with it is kind of like I previously mentioned, is that do they have a respiratory status that I can maintain in its current condition, and too many things that are risky for me to take away that patient's airway, and now that I put them in a more difficult spot than what they were previously to that. Okay. Now, the last part of this slide that I'm going to talk about is something that I preach very, very often, and it comes in two pieces. One I wrote, and then the other that I'm going to tell you. So one of the questions and that you need to be asking yourself is this airway manageable with normal BLS intervention? Airway adjunct, BVM, am I able to maintain my patient's oxygen saturations or end-tidal CO2 correctly with just basic airway interventions? And the second part to that, and I've said this on the podcast before, and Dr. C and Dr. Haley talked about this on Friday, is that I am very strong of the opinion that just because clinicians have this tool in their toolbox doesn't give them authority to just use it because they have it. Now, that might seem like, common sense, right? But I think we've all seen clinicians out there that are too aggressive when it comes to doing interventions and doing skills. And I think part of growing our profession, part of growing pre-hospital medicine is that you need to understand that just because you have a tool doesn't mean you have to use it. And I think it is way more important and way more impressive for a medic to understand not only when they should be intubating somebody, so everything that I just kind of told you, but more importantly, when they should not be intubating somebody. And that is very much specific in regards to RSI too. You have to know when you should be RSIing somebody, but also know the things in place for you to clinically determine when you should not be RSIing somebody. That's a very important piece of this presentation, and if you can take one thing away from it, that's what it would be. All right, so again, we talked about this. Things to consider: facial hair, tongue, teeth, blood, secretions, trauma, obesity, neck placement, mandible, all that kind of stuff. Also, is this patient hypoxic? And more importantly, what kind of hypoxia is it, right? Is it hypemic? Is it histotoxic? Is there a poisoning of some kind? Is it hypoxic, meaning, there's not enough oxygen, we have a decrease in partial pressure of our oxygen? Or is it stagnant, like blood is not moving? Is there a physiological reason or a cardiac reason, for instance, why this patient might be hypoxic? And that ties into, of course, our disease considerations, which we mentioned. So are they asthmatic? Do they have COPD, pregnancy, cancer, radiation, all that kind of stuff? All of those things you need to take into consideration and kind of have in the back of your mind as you're progressing down into your treatment decisions. Now, for me, this is kind of the real basic equipment list that I have ready for every single RSI that I perform. So very specifically, we need our end-tidal CO2 monitoring, SpO2. We need to be able to see their heart rate, their blood pressure, their respiratory rate, IV access with fluids, preferably IV access. In fact, I would take a jugular over an IO. You need oxygen capabilities. You need suction. You need a bougie, and very importantly, you also need a backup airway device. That's not a definitive list by any means, but those are kind of the things, the checkoffs that I have prior to me going through with the actual intubation. And when I'm getting set up to intubate, again, when I talked about this at the beginning of the presentation, it's not a slow process, but it is not a fast process, okay? It's a smooth process that my partner and I are doing. So as we're managing the airway, we're getting the equipment out, we're getting the medications out, we're seeing, where's this patient trending? What's their current end tidal? Are they in respiratory failure? Are they in hypoxic respiratory failure? Do they have an increase, like an inability to diffuse their O2, which they're low, they'd have a low PaO2 in that regard. Now, obviously, some things like that we can't see in the pre-hospital setting, such as, which I was going to mention in the previous slide, like your potassium levels, for instance. So when I talk about medications, I'll talk specifically about your K levels. And if your potassium levels are too high or too low, that's going to affect what kind of paralytics we can give you. So there's, preparation in place, and just, kind of have that list in your head of pieces of equipment that you're going to need once you kind of move into that next phase, or what we would call phase 2. All right, moving on. We're going to move a little bit faster here in the video, so stay with me. So moving on to part 2, we're going to talk about positioning, or the positioning of your patient and what's ideal for successfully completing an RSI, pre-oxygenation, and where that in terms of importance is with an RSI. Spoiler alert, it's very important. Induction and paralysis, medications that we're giving, ET tube placement, and then confirmation of your ET tube and the devices that we use in order to confirm a correct placement. All right, what does pre-oxygenation accomplish in an RSI? I'm going to preface this slide quickly by telling you guys about how and where I learned how to RSI. So during school, we do a very extensive rotation at a very prominent hospital here in the Twin Cities, where we go to the OR and we follow either an MDA or a CRNA for the entire day. And all we do the whole day is do all the intubations in the OR. I was lucky enough to have an MDA that day, an anesthesiologist that was incredible. And the things that she taught me and showed me how to do in regards to airway management, there's so many things that she taught me from that day that I still use to this day and just were paramount in my understanding of how to clinically manage patients and manage their airway. And one of the things that she taught me is not to rush in regards to SpO2. So one of the patients that that she was managing, she showed me the difference between a CRNA that was under her, obviously, that was working underneath her, that was very quick, for their RSI process, would go through it very quickly, not necessarily rushed, but would go through the steps of RSI in somebody and how that manifested itself in regards to their SpO2. And then she pulled me into another room where she did the intubation, or I did the intubation, but she was running the whole thing. And we do the whole thing. We give the medications, we give the paralysis, the sedative, and all that, or the induction agent. And I'm getting ready to kind of follow the lead of this previous CRNA that I had seen and go in really quickly and intubate. And she stopped me. And we had the paralytic and we're breathing for the patient and everything, and what she's doing is she's having me watch the SpO2 and how long it takes in a hemodynamically stable patient for that SpO2 to start dropping. Now, if everything is done correctly in regards to pre-oxygenation, you have a really long time. You have a large oxygen reservoir that allows you time to intubate a patient, normally. And this is effectively done by pre-oxygenation. So prior to that point, I was of the thought, I was like, you got to rush an RSI, you got to do it quick, you got to get it done, you got to, because we don't want their stats to drop, we don't want that, as long as you're managing that airway, and as long as they have a large enough reservoir and you've pre-oxygenated that patient enough, what she was showing me was that we do not need to rush. We don't need to rush. You can, and obviously it doesn't mean that you sit there for, 10 minutes or, 15 minutes and not do anything, but just seconds to a minute and a half or whatever it might be can feel like an eternity, right? Especially in a circumstance in the pre-hospital setting where everything is very emergent. It can feel like an eternity. But you have longer than you think you do. And as long as you have your BVM and you're oxygenating that patient and you're managing that airway okay, when you actually go into RSI and you go in to intubate that patient, take your time, look at your landmarks, call out what you see, make sure you're in the right place. Because if you get intubation wrong and you intubate an esophagus, you're gonna kill your patient. So just know what you're doing when you're intubating somebody during an RSI. And when we pre-oxygenate our patients, okay, what we're doing is we're increasing the apnea time that we have for our SpO2 to stay within normal limits and to stay above 93%, in order to give us time to oxygenate and keep that patient hemodynamically stable and oxygen flowing through their blood. And when we give oxygen in that regard, so either via nasal cannula or a non-ray breather, a patient is breathing in 100% of the oxygen that washes out the nitrogen, okay? Now that's effectively, and I talked about this in one of our previous podcasts, that's effectively initiating a gas law that the partial pressure is increasing the oxygen in the lungs and therefore increasing your reservoir. I think the reservoir of patients that are not breathing in 100% is something like 250 mLs or something like that. Don't quote me on that. But when we pre-oxygenate our patient for long enough with 100% oxygen, we're increasing our apnea time possible, and we're creating a larger reservoir for oxygen to be diffusing in that patient's blood and then therefore in their lungs. So the goal with pre-oxygenation is to achieve as close to 100% SpO2 as possible. That might not always be, you might not always be able to do that depending on the disease processes of your patient, but that's the goal, is to get that patient's oxygen saturations to 100% in order to allow us more time to calmly go through this procedure and keep that patient well oxygenated while we're intubating them. All right, moving on to medications before we get to the actual RSI checklist that we created for you. We're going to talk about the medications that we use. So for induction or for pre-induction, we use either etomidate or ketamine, and then for our paralytic, usually either succinylcholine or rocuronium. I'll talk about vecuronium a little bit in post RSI care, or how it can be used as a paralytic in the initial part of an RSI, but I'll get to that in a little bit. So the main medication that's used as a pre-induction agent right now is ketamine, and ketamine, I think, is universally used that way. It's used very often in the ORs, which was surprising to me. I mean, for a long time, I always thought that propofol was going to be that main induction agent in the OR, just because it's much more readily available in the hospital than it is in the pre-hospital setting. But ketamine is used very often in the OR in the same way that it's used as an induction agent in the field, and that's because it's a great drug. It's kind of a wonder drug that has been around for a long time, but for me personally, I have seen it really come about in the last 4 to 5 years. It's very, very often used in regards to excited delirium. That's probably where most people know ketamine to be useful. And in that kind of a scenario, it's kind of a light switch, right? So if you compare it to like a B52 or a Haldol or droperidol or something like that for excited delirium, ketamine is a light switch. It's used it brings the patient from being in that excited state, down to completely sedated in a very short period of time. So it's a very powerful medication. Should be used correctly in that regard. But for RSI, which is what we're talking about here, it's a great drug, and it's great in hemodynamically unstable patients. It actually has an increase to your blood pressure, which is why we don't use it in cardiovascular patients that have cardiovascular disease. So patients with CHF, ACS, that kind of thing. It's very quick acting. Usually takes about 60 seconds. In fact, I would probably argue even less than that. And the dose is obviously dependent on the service that you work for, but typically you'll see around 1.5 to 2 milligrams per kilogram, and the duration is about 10 to 20 minutes. So for an RSI, for instance, the reason why it's so useful is because you're using it as an induction agent, and then you're giving your paralytic in conjunction with that, and then you're intubating your patient, and you still have a pretty good amount of time of ketamine that's working in the patient to be used as a sedative. So it allows you kind of a larger gap to get to your post RSI sedation and analgesics, which can kind of get lost in the fold. And again, I'm going to talk a lot about that here coming up. So it's a great induction agent, used very often. There is a shortage right now throughout the country, which I think everybody is kind of feeling. So yeah, it's a great drug, and probably will be the drug of choice for a long time going forward with induction.
What's going on, TMAP Nation? Alex here again, back at the house here in Dakota County. Got a brand new summer haircut because it's hot out, and I am ready for trauma time. I'm here to answer Greg's next question: which drug is superior, succinylcholine or rocuronium, for induction during RSI, MAM, or DFAM, whichever acronym you prefer. So a study came out, what we call a meta-analysis, which means it looks at all of the papers regarding a particular topic as to which paralytic was superior for creating good intubating conditions. The answer, surprisingly, was actually succinylcholine, but that was an article from anesthesiologists, which means in the OR, Sux is probably the better drug. They have more control. We don't have that control, so I'm going to lean to rocuronium. Fewer side effects, a little bit better safety profile, a little bit less hemodynamically reactive. It's a good drug all the way around. The only consideration is that it does paralyze a lot longer, so we've got to be great with our airway management skills. Again, I think I'm going to go with rocuronium just based on the fact that there's such lower risk of things like hyperkalemia, malignant hyperthermia, and the like. So that's my answer. Rocuronium beats succinylcholine every time. See you guys later.
So after our induction agent, we have our paralytics. So these are the medications that need to be very, very, very carefully understood by paramedics out there that are performing RSI. So the main paralytic that is widely used, not only in the pre-hospital setting, but in the hospital setting, is succinylcholine. I'm sure you've heard a lot about it. We have done many of the daily quizzes, or I should say I've written a lot of the daily quizzes on succinylcholine. It's been around a long time, and is very, very useful, but has a lot of contraindications that you have to be very, very careful when you're administering it, which this ties into why I think that RSI should only be performed by 2 paramedics. And I'm going to get in and talk about more why I believe that. So succinylcholine is administered as 1 to 2 milligrams per kilogram. Its onset is very, very quick, 30 to 60 seconds. Again, I would probably argue even less than that. Its duration lasts around 6 to 10 minutes. Again, I would argue even less than that because its half-life is so short, but is widely used as the first-line paralytic for RSI. The problem is there's a lot of different contraindications that come with it. First and foremost is hyperkalemia. So in the pre-hospital setting, a lot of people don't have iStats. We don't have labs. We can't, tell what that patient's K level is right at that moment. But we can tell what their potassium is doing based off of their heart rate. So if a patient has elevated T waves, for instance, a widening QRS, a QTC segment that is interchanging, and we have elevated T waves, that is indicative of hyperkalemia, which is indication to not give succinylcholine. Okay. Now that's going to make more sense when I get into the checklist and kind of the rundown of how to perform an RSI here. I'm going to talk about here real quick, but this is why you need 2 paramedics because as a patient, or as a paramedic is managing that airway, the patient who's in charge of medications is also paying attention to what their EKG is doing and several other things in regards to that. So we cannot give it in patients that have elevated potassium or elevated K. Malignant hypothermia, burns greater than 24 hours, crush injury, neuromuscular disease, bradycardia. There's a lot of contraindications that go into succinylcholine. So you have to be very careful when you're giving it and pay very close attention to what your patient is telling you hemodynamically. So the alternative to succinylcholine is rocuronium. Rocuronium is very popular, but not as widely used, I should say, at least in my experience, as succinylcholine. I would prefer to use rocuronium. Our medical direction has used Sux and RSI for a long time, and we do have rocuronium in the critical care setting at the organization that I work for, but is still not typically used in the 911 setting, not just where I work, but kind of system-wide in regards to the state of Minnesota. So rocuronium lasts a little bit longer, or not a little bit, I should say much longer than succinylcholine does. Onset about 1 minute, takes a little bit longer to kind of kick in, but it does essentially the same thing without all of the contraindications that come with succinylcholine. So it rapidly distributes into the extracellular space. And the only real contraindication that I have seen, that I have read with rocuronium, is to be used in caution with patients with previous hypersensitivity to the drug. How do we know that in the pre-hospital setting? Well, we probably don't if we're RSIing somebody. So not a lot of contraindications for it. And I would argue probably a safer drug to use, but it does last longer. So the thought behind succinylcholine, and this is probably more especially important in the hospital setting, is that if you give a paralytic like succinylcholine, for instance, and you can't establish an airway, you can't intubate a patient, or place a successful airway for that matter, then the thought is that you can pull that ET tube out, or that supraglottic airway out, and then place an adjunct and bag that patient and keep their stats up and keep their airway patent until that paralytic kind of wears off. I don't know, and again, this is a biased opinion, I don't know any paramedics that I work with on a regular basis who would wait for succinylcholine to wear off and not establish an airway at that point. So, and again, that's kind of where my biased opinion comes in. But if we're giving a paralytic and we're not doing that hospital-based setting where we're waiting for succinylcholine to wear off, where a patient can start breathing on their own, and we're choosing to RSI a patient, which ties back into knowing when we should be RSIing somebody, when we should be doing this procedure, and when we shouldn't. If we've made the decision to do this procedure 100%, okay, then we need to be able to establish a patent airway with an airway device 100% of the time. There's no middle ground. So if I'm giving a paralytic, this patient is going to be managed, their airway is going to be managed in one way or another. And I've never given succinylcholine or RSI'd somebody and just waited for them to wake up off of it. So maybe that's more of like a hospital-based mentality. I don't know if that's common in the pre-hospital setting. Again, give us your thoughts on what you think about succinylcholine and if that would be a scenario that you might do. I mean, I understand the logic behind it. I understand the thought process behind it. I just, if I'm RSIing, I need to be aggressive enough to manage that airway one way or another and make sure that I have a definitive airway in place. That's why I need an ET tube, and I'm just not going to wait for succinylcholine to wear off. So, my opinion, let us know what you think. All right, now we've finally arrived to the main part of this video. So, what you're seeing on this screen right here is something that I created that you've probably seen in one form or another in your service that you work for or online or whatever it might be, and that's just an RSI checklist or an RSI algorithm that you go through to perform an RSI in the pre-hospital setting. I put this together because a lot of the ones that I see online are either very short or they're very they don't include other things that I typically do on an RSI that maybe are kind of innately done subconsciously by paramedics or whatever it might be. But I thought it was important to kind of put onto paper how I think about RSI and how I typically go through it. So I thought this might be useful for people to kind of look at. That being said, there's a lot of information on this. So I'm going to leave this up on the screen for about 20 to 30 seconds, maybe a little bit longer, so you can kind of look over it real quick. And then I will come back and we will start talking about it. All right, so let me give you a breakdown on kind of how this works. You can see here that there are two medics on this checklist, on this algorithm. Maybe I should find a different word to kind of describe it because I'm going to say that a lot here real quick. So medic 1 is in the orange, which you can see on the boxes to your left and then down to the right at the very bottom. And then medic 2 is in the green. So those are established with each individual medic in their role. In the middle there, you have a blue combined column, and that combined column is something that both medics should be doing in parallel to one another during an RSI. Those are things that either person can do or, again, done together. And that's the first column that I'm going to talk about. So obviously the first one is placed onto a stretcher. Your patient is in a position where you can perform an RSI. That obviously doesn't always happen. You might be doing an RSI in a house or a vehicle accident or some other austere environment that isn't the back of your ambulance. And that being said, this checklist is specifically just for adult patients too. We're not talking about pediatric patients. We're not talking about anything other than your adult patient, okay? So your combined column, you have patient is on the stretcher. That's something that's kind of done universally or together, right? You should determine your first responder assistance. So do you have police there? Do you have fire there? Do you have individuals that can drive the ambulance to the hospital with you and your partner in the back of the ambulance? Now that's obviously service dependent. Some services let their police and firefighters drive their rigs. Some services, that's against policy. So obviously, it goes without saying that this entire thing is entirely dependent on your medical direction, the service that you work for, and always refer to the disclaimer at the beginning of this video in regards to any of its content too. So as we move down the columns there, you'll see that there is a yellow box there, third from the top down in the combined column. That's the same as the timeout, which is further along in the RSI. Those yellow boxes in those columns are a point where you can really step back and say, this is not a procedure that should be done on this particular patient that we're taking care of. And at any point in time during your RSI, for that matter, if at any point you find that it's an impractical or unnecessary procedure that's going to be performed, you should abort. You should try to figure out a different way to manage that patient. An RSI procedure is something that is really critical. It's risky. It should only be performed by the highest level provider. And you need to be comfortable with it when you're doing it. So that third box down from the top is determining and estimating airway difficulty. And we talked about that earlier in this video. Are there things in place that would prevent you from successfully getting an ET tube? You have to think 10 steps ahead. You have to think down the line of what's going to happen with your patient. And if you can't establish an ET tube, or you figure out that this airway is too difficult an airway in the setting that you're in, figure out other means to manage that airway before you perform that RSI. And the first one down is to inform, instruct, and educate. Now that goes for the first responders that are around you, but also each other with you and your partner. You should be talking your way through this procedure. You should be, openly communicating with the first responders, the people that are there with you, on how this procedure is going to work. Because if you just sit there in silence and you're not keeping people informed, that usually ends up with bad results. So you should be informing the people around you. You should be instructing the people around you. And what I like to do is I like to educate the people around me. So I explain why I'm doing something. What's the next step I'm looking for? And I think that brings people involved into the process, and it makes them more comfortable in that regard. And then after that, we have you want to reevaluate your environment. So are you in a place where you maybe shouldn't RSI? Maybe you should extricate a patient to a more comfortable environment, like the back of your ambulance, for instance. Reevaluate what's happening around you. It's really easy for medics and for docs and anybody for that matter to get tunnel vision when they're doing high stressful procedures or procedures that elicit a high level of stress. So if you're constantly reevaluating the environment around you and the people around you, on top of evaluating your patient, which again is another point why this should be done by two paramedics, that will kind of keep you more calm, make things run a little bit smoother. So it's in there to remind you to constantly be looking at the things around you and not getting tunnel vision. And then lastly, obviously, you want to position the patient in a position for success. So placing their airway in a position that is going to be useful for you to accomplish success, which is, again, something we talked about earlier in the video. So in the top right-hand corner there, you see a column that says helpful tips. And these are things that I truly believe in when you're doing this procedure, and things that you really need to take to heart and keep in mind while you're going through this very risky and very stressful procedure. I've seen a lot of people get stressed out to the point where they are just, blobs of themselves. They can't perform. And I understand that because it's a stressful procedure. There's a lot of risk to it. There's a lot of responsibility to it. And again, that's just another point in why there should be two medics doing this. I mean, it's one of the most advanced procedures you can do in medicine and in the pre-hospital setting. So first and foremost, be calm, be collected, and be directive. There's an adage out there that I'm sure you've heard before, and it is especially true in RSI, and that is that slow is smooth and smooth is fast. If you are rushing through this procedure, if you are going faster than you should, you're going to miss something. You're going to make a mistake, and you're not going to notice it, and it's going to be harmful for your patient. So be meticulous in every single step that you're going through. Know what you're doing and understand what you're doing and know what the next step is and know what the next step after that is. The biggest problem that I have with algorithms is that I think people look at them and they're like, I just need to memorize these steps and then I'm good. And that is not the intent of this image that I created. And I would argue that's probably not the intent of most algorithms. Most medical directors out there would tell you that. These are just reminders of what the process is and the steps that you should be taking during a procedure. So if you're rushing through an algorithm, if you're rushing through the next step, and you're not slow, or I should say, if you're moving too quick, you're going to miss something, and that's really where mistakes happen. So slow is smooth and smooth is fast. I live by it with these kind of procedures that I do, and I honestly believe that you should too. You should communicate. And then after you communicate, you should communicate some more. Do not be silent during this procedure. Talk to your partner. Tell them what you're seeing. Talk them through what your thought process is. Now, I'm lucky enough to work with several partners who I do most of my shifts with, who we are very comfortable with each other as we're working, and we trust each other. And it's easier for those of us who have kind of regular partners to communicate less during a procedure because we kind of already know what the other person is thinking. But you should still be talking to your partner. You should still be, walking through your process and again, what you're seeing. If you're not communicating, if you're staying silent, it leads to problems and it's going to lead to mistakes. And more importantly, I think communicating with your partner is important for the first responders and other people that are there on the scene with you so that they understand what they're seeing and they understand what's happening. Maybe they're seeing something that isn't what it actually is, but they're perceiving it in a certain way. And because you're not communicating correctly with either your partner or them, their mind's going to start wandering on what you're doing. So openly communicate, and then obviously communicate beyond that on what you think is appropriate. You should know what's required of yourself, and you should know what's required of your partner. Both of you should know both roles. You should know what the step is for each person, and you should be working parallel to one another, right? So if I get an RSI, or if I'm doing an RSI with some of my regular partners, we're working parallel to one another. If I'm out on a car crash or a patient with a severe head injury, and we have to RSI a patient, and it takes extrication of that patient from the environment they're in into the back of the ambulance, my regular partner, and I will split. One person will manage that patient with first responders. The other person will go to the rig and start getting stuff ready, right? That medic one in this scenario, or it could be called medic, A and B. One patient is one paramedic is getting everything ready and set in the rig, and the other patient is managing that patient with first responders on scene. And you're working parallel to one another, right? To reduce the time it takes to adequately treat this patient and then inevitably get them to definitive care. So know what's required of you and both your partner. Own your duties and responsibilities. Okay. This is a big one. And then most importantly, slow your breathing. That might seem simple, but slow your breathing. Take a deep breath. Think your way through the problem. Think your way through these scenarios, through this kind of a procedure. If you slow your breathing, then maybe your partner that's amped up is going to slow their breathing, and maybe the first responders are. And it's kind of amazing how easy it is, both negatively and positively, your presence as a leader on a scene like this reverberates to the people around you. If you're amped up and you're nervous and you're moving at 1,000,000 times a minute, that's going to make the people around you nervous. If you are calm, if you are collective, if you are directive, if you are putting other people in a position to be successful and you're being a leader on that scene, it's going to make them more comfortable. It's going to calm them down. And I promise you that is going to be way more successful for you and your overall patient care. All right, so the last thing that I want to talk about for this slide and for this video is post-RSI medications. One of the biggest things that I see people miss is utilizing medications to continue to sedate your patients after they've been intubated. And this is a big issue for me, and we've talked about this at length on the podcast before, but having somebody paralyzed and intubated without proper sedation and without proper pain management is criminal. That is just, it's so unacceptable. After you have successfully performed an RSI, after your patient has been successfully intubated, your first priority should be making them as comfortable as hemodynamically possible. And that includes sedatives and pain management in your post-RSI medications. Obviously, it's dependent on the patient hemodynamically, if their blood pressure is stable, if they're stable. But you do not want to have your patient intubated and or paralyzed without proper sedation and pain management. Talked about it at length. Utilize your post-RSI medications. That is a huge, huge, huge thing that you need to start doing if you're not doing it already. And just pay attention to it and be diligent in managing that patient after a successful ET. RSI intubation. So we're making sure that your patient is not undergoing tube stress. They're not breathing against the tube. They're not fighting you on your ventilations. If you're placing them on a transport ventilator, that they're as comfortable as possible. You want to utilize those medications, and it's a huge part of what is happening after an RSI. All right, that's going to do it for me here at the Medic Assessment. Again, my name is Greg. I hope you guys really enjoyed this video. I know it took a long time for us to edit and to put together, but we wanted to really get some important pieces in there, and hopefully you guys got a benefit out of watching this video or learned something new. Again, Alex and I very much differ in our opinions in regards to RSI and in regards to who should be allowed to do it and the amount of personnel that should be on scene while you're doing this kind of a procedure. I very much believe in the medic mentality. I think that's how ambulances and EMS services across the board should be in pre-hospital. I understand that's also not totally possible in every part of the country, and that's perfectly fine. Again, it's my opinion, and Alex and I very much differ in that regard. And hopefully that gives you a perspective that we don't always agree, just like most advanced clinicians and people in pre-hospital medicine, or medicine for that matter, don't always agree on everything. And I think that hopefully provides enough of a platform for you to come to the TMAP community with your own perspective and your thoughts in the process, respectfully so. And again, Alex and I disagree all the time on many different issues, and this is one of them where we do disagree. So hopefully you enjoyed the video. Thanks for watching, and we will be back later in the summer with some more content. See you then.